All right, good afternoon, everyone. I think we will get started. I see people are still joining, which is really exciting. I invite all of our panelists to turn on your video if you're able to, so we can see you, and we'll get started. So welcome. My name is Adeline Azrack. I'm Managing Director of Fondation for the Americas. And so in addition to working for a foundation that has worked in Haiti or partnered in Haiti for many, many years and continues to be very committed to that work, I actually started my career, my public health career in Haiti at Hôpital Schweitzer. So Jessica is representing Hôpital Schweitzer today, and spent really many years just appreciating so deeply the 4 organizations represented on the call today. I have either worked directly with you or peripherally with you and have just great admiration for organizations. So I'm really pleased to host this conversation today that really has 2 purposes. The first purpose is to create a direct communication between Haiti health administrators and donors. This kind of direct communication does not happen often enough in philanthropy in general, but specifically for Haiti-related philanthropy and aid work. Second, I hope that in the course of this conversation, we can really challenge and reframe some damaging narratives about the Haitian health sector and health funding in general. And I guess I should say third, I'm going to hit you all up for money. So I'm just going to be very clear at the start that we're going to be asking you to all, consider your funding allocations to Haitian organizations, not just how much you give, but the way that you're structuring your grant making in Haiti. So before we just jump right into the questions that we have for our panelists today, I want to offer just 2 quick reflections. The first is, what is a health system or what is a health institution? That sounds like a very abstract concept, and we kind of think of buildings and supplies and equipment. But I'd actually like to posit that a institution, any kind of institution, is the people and their relationships to one another. That's what an institution is. So when we think about supporting Haiti's health sector, let's certainly be thinking about the supplies and the equipment and the infrastructure. But I would like to frame this conversation today about really supporting the people that are, at the end of the day, they are the health system. And they are human beings that are working incredibly hard right now under tremendous pressure. Second, we all know that many donors are stopping or scaling back their work in Haiti. Right now, they say it's because of donor fatigue, etc., or that their funding doesn't seem to be resulting in progress. So first of all, that's patently untrue. And so we need to challenge that narrative that funding isn't having tremendous impact, because it is. I think it's just we have a challenge in telling the story well and framing that narrative. But it's also our fault as funders. And I'm speaking here as a funder and as a board member of an institution in Haiti. We as funders kind of go nonprofit shopping, and when we have funding to give away, we try to find the most deserving institution. I'm using deserving in quotes again, with the most deserving clients. And this deservingness narrative that we use in philanthropy is really deeply problematic and is hurting our work and hurting communities. So I'd like us all to sort of I invite you to entertain some thoughts about how you think about selecting organizations and what are your underlying assumptions as you're approaching that. And maybe consider, what if instead we looked at networks of organizations? What if we looked at relationships between organizations, communities of organizations, and we asked them, how can we support you better to work together as a community and not compete for funding, but actually jointly leverage all of their different skills and relationships to make a better impact together as a community. This, I think, would make Haitian organizations more shock resistant, more resilient than they already are, and actually help our funding as donors to have a much greater impact, because we're building sustainable networks. So one beautiful example of a health system network that I think is already thriving, but could be even better and could be invested in further, is this beautiful community right here of Health Equity International, also known as Hôpital and Boniface, Haiti Air Ambulance, Zanmi Lasante, and Hôpital Schweitzer. And what an incredible network of organizations that's been there for a very, very long time. And as I'm learning now, it's really Haiti Air Ambulance that's starting to, on a very logistical level, increasingly connect them to each other. So with that, I think I'd like to start with some very quick introductions. So inviting the panelists, starting with Dr. Cadet, could you please just a very quick introduction, who you are and where your organization is based?
Okay, thanks, Adeline. My name is Wilfrid Cadet, and I am the Chief Medical Advisor for Health Equity International. The main office is in Newton, Massachusetts. Our operations are in Fondation, the south of Haiti.
Thank you. Over to you, David.
Hi, good afternoon. My name is David Ellis. I'm the Executive Director for Haiti Air Ambulance. We're a 501c3 based on Long Island and operate out of Port-au-Prince.
Over you, Dr. Julmisse.
Hi, not a doctor yet.
Almost done.
I'll finish my doctorate in a couple of years. My name is Marc Julmisse. I am the Executive Director of Zanmi Lasante.
Okay, and Jessica.
Hi, everyone. My name is Jessica Laguerre. I am Chief Operating Officer for Hôpital Schweitzer, and we are based in the Altibonite.
All right. So the first question that I'd like to offer to the four of you is really, why do health organizations in Haiti need to work in deep partnership with one another? Like, what's at stake and what is to be gained by working in deep partnership with one another? I invite you to just jump in. This can be spontaneous.
Okay, Marc, please.
I think last year actually showed the importance of us even more so with the crisis that we went last year, with the fuel crisis, with the heightened security issues that were happening, with the delays in getting supplies in from the containers, with the delays, with all that happened. It just showed how much we worked well together, because we set up this informal network of organizations and communicated with each other, asking each other how much fuel did you have, sharing across. Some of us, even now in the Artibonite area, for instance, saying, can you hold some of our staff because the area that they're in is just way too dangerous. Exchanging of clinicians and saying, we just can't bring our clinicians in. You know, what can you send us one, or what do we need to do? Or letting each other know, saying like, hey, I have this bed space. Can you take these patients for us because of the situation that's happening? And knowing that I'm going to be short on fuel and can't manage, or have the potentially of not being able to manage. And then even working across and advocating these last years, putting our voices, collective voices together, because although we have to treat patients, it's at this side, or we have to manage the situations. I think the big part was advocacy, and this has shown even more so. We've done it, but I think this year you've seen it, this last year and this year you've seen it even more, where the organizations are talking more to each other and saying, how can we support each other, putting aside organizational pride and saying it's about our patient and about our mission.
One other reason for working together, especially now, is each organization has a certain reach. You mentioned last year, but everyone knows that it can be challenging to work out the public system in Haiti, whether this is education, health, or finance. So sometimes you need another organization to reach out to whoever is in charge somewhere within the public system to get that paper signed or that approval done. So there are many reasons to get together and really to deliver on the mission of each organization and collectively the work what we are trying to do in our communities in Haiti.
I completely agree. Every time that we've been able to get, whether it be face-to-face or via Zoom with other organizations, we really start to solve a lot of problems. You know, there are a lot of resources that are in Haiti that, you know, we're geographically siloed away from each other, that a lot of times we just don't realize that we've got a solution to someone else's problem. And it may be really small things, but we all know that trying to operate here, really small things make a big difference a lot of the time. And sometimes we're able to solve some really large problems, like Marc mentioned during the fuel crisis. You know, if it hadn't been for our partners, we would have absolutely been out of service. We were able to leverage partnerships and you know, allow all of us to remain functional.
And I just want to add as well, outside of, you know, collectively problem solving, when we get together and meet and exchange our ideas, I think a key element of this for us in our service area at HAS is that as leaders in the healthcare sector, all of us here, we have a certain responsibility to smaller nonprofit and healthcare institutions as well, and public hospitals as well. And I think last year, staying true to mission meant supporting these efforts as well, right? So if it's oxygen or fuel, if the Verret Health Center that's near serving the same community I'm serving is out of service, we're not staying true to mission. So it is our responsibility, if we can, to share fuel with them. Same with oxygen. Like when the roads are cut off, we have a certain responsibility, not only to exchange on a larger scale with, you know, large partners like ourselves on this call, we also, I think, kind of have to step up and take on some of the responsibilities associated with smaller institutions in our service areas. So, you know, whether it be helping them with oxygen, with fuel, support with materials and resources, I think that's a big part of it, and something that we really stepped into last year because of this, you know, political situation and the insecurity, and especially the fuel crisis.
I think that's a great point, that we need to pivot from, you know, trying to survive and do what's best for our organization and really look at what our underlying goal is. The underlying goal is care for the patient population in our catchment area. Mm-hmm. And what do we need to support that, whether it be our organization or another.
Adeline, there is one thing I would like to add, which is something that I really value, is really to do what we preach. We encourage communities to come together, different organizations in communities to work together. And then if they see us as big partners, big actors in those communities not working together, what kind of message we are effectively delivering? I think it's a teaching mechanism when we work together, especially in a context like Haiti now, where the sense of community is kind of disintegrating. So we need to work together, to come together, so we can transmit that mechanism to communities that we are working with.
Well said. I'm hearing really clearly from you that you are each other's risk management, and you're actually the risk management for much smaller organizations as well. Often when things get really complicated, your own risk management mechanisms fall through, your own supplies fall through, et cetera. But in partnership with each other, you could usually find a way to get through it. So this is really about maintaining resilience and growing resilience. You each have different strengths. You each have different catchment areas. You each have different relationships with other community-based organizations and public organizations. And then that last point by you, Wilfrid, thank you, is really like, let's as community leaders, let's show an example of what partnership and community building looks like. So related to that, we know that partnership building and working together, that takes work, that's real work. And you're all managing very, very busy day-to-day things, and some of you are actually treating patients. How can donors, like what behaviors do donors need to change or do differently to support you to work in partnership and to grow the strength of your community as a group?
Adeline, I think last week I was part of this great exchange with different nonprofits and funders, and we really discussed trust funding. And I think that's really key in this current situation in Haiti, that we need to look at trust funding as an option and move away from a traditional MOU, program-oriented indicators as result, or, you know, performance-based indicators to show impact. The reality of the situation in Haiti right now, what donors I think need to understand is that we're shifting and constantly changing our strategies to have an impact. So for example, if I used to transport my team to one of the mountain health centers and, roadblocks and having a truck out on the road with the security situation is not the best approach. Donors need to give us the flexibility to say, I know this is restricted funding for truck and maintenance, but I'm going to use that to use local means of transportation to get my team to the site. And I think there needs to be that flexibility for us to really adapt and continue to provide the services that we're providing in Haiti right now. Like fuel, for example, what we anticipate, I think all of us are dealing with the same thing here. What we may have budgeted or anticipated in fuel is not the reality that it is now, maybe from last year, the year before. So being able to shift some of this funding to provide fuel is essential. I think when we're talking about a crisis situation, the most supportive a donor can be is really to allow us to make the best decision that we feel like we need to make in this current climate. And sometimes that's not gonna show up in numbers or the number of consultations or the number of patients that were treated. It's gonna show up in just simply being that we were able to keep this service going. And the flexibility and the creativity that's required to do that in Haiti right now is through the roof. Like you constantly have to shift things. So I think that's the biggest part. And also partnerships and strength building does not look the same. Like the traditional MOU is not how we're partnering right now. Sometimes it's about, hey, Marc, I'm completely out of gloves. I can swap gloves for this, right? And it's saying, okay, no problem. I have my team deliver and your team can pick up or things like that. And I think the more we're focusing on keeping operations going, which is very challenging in this current situation, the more we will count on our donors to understand that this situation is constantly changing and shifting, and strategies that we're able to implement last year have to change this year to keep things going.
I think from for answering the question of how do we encourage donors to look at that, I think that would be something that, rather than funding an individual project, fund an operation that's a requirement that several different entities are pulling together. One thing fortunate with our organization is that we have access to the whole country. So, rather than being geographically restricted, we get to see the way people are operating all over the country. And there are lots of best practices out there that not everybody knows about, and lots of things that can complement what other teams are doing. And I think as a donor, if you look at it from a standpoint of, what coalition can I fund that's going to help everyone bring this up? We can make 2 + 2 = 5 or 6 with combined efforts, and just really increase the benefit.
And as much as, sorry for being so direct, as much as donors like to talk about sustainability, but we all know that sustainability is a process over time, and very few donors really want to commit to provide long-term support or long-term partnership to any organization in the process, let's say, of building resiliency to natural disasters, to improving income in the community, or to just improve neonatal health. So because that takes time. And also the other point, and I think I really like the key element in Jessica's answer, the flexibility. We all know health has, is a multifactorial thing. So the focus on one particular domain in topic really limits how much and how far we can reach. So that flexibility is important, as much as I would say the time that it takes to build partnership, to find one another and to align our goals and our strategies, and effectively to implement the partnership every day. And of course, just like in any relationship, there will be good days, there will be bad days. So, but it seems like everyone wants to look at the bad days. It has to be a smooth, linear process, and it is not like that, as we all know.
I would even add, and Dr. Cadet, you touched on this, is really looking at overall, looking at multi-year funding. I'm not talking about 1 or 2 years. I'm really saying you need at least a minimum of 3 years. Because if you're considering starting even a new project or new program, that first year it's going to be delayed gathering your team, hiring with all the issues that are going concerned. By you going to that second year, but even when you're starting that second year, it takes time to get the impact that you want, either buy-in from the patients or those that you're serving, buy-in from the staff, for them to truly understand. Because even if you start, they might not truly get the full concept, the ones that you're in, and then also buy-in from the local government that we're serving, that we're working with, so that they see that we're partners and we're not just pushing a program in on them. So I think literally, if we really want to start showing results or I think we have to start looking at, and this is something I push with any conference I go to. If I have opportunity to talk to donors and funders and grantees, say like we need to really consider a multi-year funding. The best partnerships I've had, I was saying, where the donors, I know this is not possible with many of them, are involved more. Sometimes it's a challenge, but then they get to a better understanding of what it is, and I see them to be more flexible, where they are, aside from our regular communications, aside from our scheduled communications, they've been involved, and I've seen they have been a little bit more flexible because they understand the situation on the whole. And I think there's another thing that you had sort of brought up, Dr. Cadet. I'm missing it right now, but I think that's one of the big parts of it. And one of the parts is also not looking necessarily at the trends of what's going on. I think looking at what the service population needs or the community needs, because I know sometimes we get locked in and say, hey, we're going to do finance-based, thank you, results-based financing, right? However, I think part of it is, and I'm talking not just about donors, I'm talking about I'm talking about funders, international funders also, in changing their policy. Because there was conversations, because we lend our voices and join our voices with the ministry also. There's conversation that has happened and said, like, this is not going to work. However, because they come with, this is the amount we're giving you, this is what we want you to do, it has to change in that, because then it doesn't work. And then you blame the ministry, the government, for not being able to achieve those things. And they said from the beginning, it's not working. Taking COVID, for example, there's things that we said from the beginning, that's not going to work. They were like, well, you have to. I'm like, it's not going to work. And then when it didn't work, they were like, why didn't Haiti reach up to all your vaccinations? I'm like, because we told you what you gave us and what we said wasn't going to work. And so I'm like, please don't blame. And now the narrative, we're saying, don't blame us. So in that thing is really listening to the team on the ground and not going with the preset idea of what needs to get done.
I want to really sort of amplify what all 4 panelists have just said, which is there's this basic principle that those closest to the issues have the best solutions. And what that means, that is the whole basis of trust-based funding. It's about donors don't have the answers. We don't, even if you've been studying Haiti or you've been working in Haiti for many, many years, you don't have the answers. It's the administrators and the health workers that have the answers. So trust-based funding means letting go of your own ego and your own need to try to prescribe outcomes, and giving full sort of authority and encouragement for local solutions. I'll recap some of the other really, really clear action points at the end of this, but I just wanted to really take a moment to uplift that. If there's one thing that maybe we can all take away from this, it's those closest to the issues have the best solutions. If it's okay, I'd like to pivot to now our people, the people that you all work so closely with every single day. So Haiti's health system is its health workers. And we often hear about the tremendous resiliency of Haitian healthcare workers. And while that's often, of course, very well intentioned, I think that this kind of constant celebration of the resiliency of patient health workers can normalize the unreasonable demands that we're placing on healthcare workers. So as if sleeping on the hospital floor and not going home to your family at night because it's not safe or because you're too overworked is somehow heroic resilience. I would actually say, yes, it is heroic, but it's also tragic and not something that we should be expecting of human beings who want to perform at their best. So I would like to ask the four of you to sort of reflect on that a little bit and how can we as partners support health workers better, patient health workers better, and kind of counter this harmful narrative, this expectation of heroic resilience at all times.
I'm so happy you brought that up. Actually, that has been for the last 2 years, actually 3 years, that has been one of the things that I've been talking about fairly widely. And we turned that, and this is not me that coined this term, Devereaux's coined this term in his articles. It's pathological resilience, essentially, because there's your only other option is to roll over and die, and we're not doing that. So the resilience that we're glorifying is at the same time, yes, we're getting it done and we're moving it forward. But I think some of the ways that we help is, and we instituted a staff wellness is because we recognize that we have to address the mental health aspect of it. We can't expect our staff to deliver the quality that they need to deliver when there's still trauma, because we have acute and chronic trauma that continues to happen. And we're asking them to deliver where they're still dealing with their ongoing trauma. We might not be able to change the situation in Port-au-Prince or the gang and all that stuff. However, we have to address and keep mental health capacity. And I'm asking donors, like, can you add that in as part of our program package so that it's not an afterthought, it's part of what we're doing. Second part is housing. In our context, and I'm specifically in Haiti context, we have to consider, and maybe in some other contexts, in some of the other countries we serve, we have to consider housing for staff and not having them sleep on the floor. What we're looking at is housing for families also, so that they have the ability. And even when we opened our health center outside of the crisis, is you have to consider on-site housing that has to be planned in there, so that even without this, you have to imagine the trajet going back and forth and the fatigue that we have, the work hours that they have outside of the crisis. And now you're adding on top of the crisis. So we're just increasing onto that fatigue that was at least baseline already. So there's multiple other things that we could, that we have a list, but I do want to hear of the other panelists.
For me, I'll summarize it with 3 key words, and basically build on what Marc has said. I mean, even in normal times, health worker has to work in very tough conditions in Haiti. I still remember, my shifts at the State University Hospital, where we are overcrowded in a neonatal emergency room. I mean, there's no space. There's space for the health worker to work in. That's critical. So they can have some level of comfort within that space. Because one of the complaints that I hear, or I can go on and on about this, is like, the Haitian health workers, they are rude and they don't treat the patients well. Yes, we acknowledge that, but we also need to look at the conditions in which we put those people to work. And I can attest to that, and I can witness that. And when you have too many patients like to take care of, at some point, you lose it. And especially if you've been doing it like for 2 hours, 4 hours, 6 hours, 8 hours, it has a toll over you. So then the working conditions have to be improved. And the other element is really the supplies. People are working in some settings with their fingers, almost nothing. I mean, we are blessed, and I'm sure Marc can say the same, and HES can say the same. We are blessed to have enough supplies for our staff to work with. And that gives them some sense of worth, of relief. When they see a patient coming in, they don't have to worry about the IV, the antibiotic. And at the end of the day, they can see the results or the transformation of what their work has done to that particular patient. So that's true. And the social package, let's face it. You have young professionals who do not see far into their own future, or those who have a family who don't see anything for their children, because the salary is what it is. So some organizations have a loan program for their staff, but as much as this can cause accounting challenges, but sometimes before the end of the month, the employee comes to you, oh, can you loan me X amount so I can pay my child's tuition? So the social package, and you mentioned housing, it has to be improved.
I agree that we can't just expect people to show up. I've had a physician whose house was attacked and burned, and several other staff that have had to abandon everything they own. And we have to acknowledge that. We have to look at the whole picture, that we need them to function in our program, but at the same time as an organization. And I think this feeds up to the donors, that has to be acknowledged, that we have to take care of our staff, and the funds have to be there for that, for us to be able to do that adequately, to enable them to do the really difficult work that we're asking them to do.
Yeah, I definitely agree with David. Communicating the need and how we're having to shift and adapt, especially with staffing, with the current crisis I think all of us are facing, with a great deal of professionals leaving the country. There are certain layers and certain steps that we as team leaders need to take to make our staff feel more comfortable and encourage them doing this work, and also acknowledge their trauma. But I think for me, and when I speak with my team, like for example, our chief of surgery, Dr. Ashal, his feedback is that the real injustice would be to not have the service for the greater population, right? And I think as crazy as the idea of resiliency and this continued resiliency that Haitians continue to display and we show up with every day, the reality of it is to not do it, what happened, right? And that's what our team leans on. Like, what would be the impact of HES no longer being present in our service area, not having access to these emergency services, essential services, to the 350,000+ people that we serve? We lean heavily on that at our institution, and our team really reinforces the message. And I think, we do provide the housing, we work to create a different culture, we try to acknowledge the challenges and the trauma, and also create a safe space for sharing and leisure on campus, right, while at work. But I think, in any country, in times of crisis, there are some of us that really have to step up. And I think in Haiti, it feels like it's not a time of crisis because we've been doing this for some time now, but it is, right? Every day we're showing up, and it is a crisis like any disaster. It's like an ongoing disaster relief effort, and our team is leaning heavily on that. I think it can be problematic to share and celebrate the resiliency, but I do think it is important to continue to highlight it and really tell the story, because it's miraculous work, it's amazing work, and it's really a sacrifice for country and sacrifice for Haitians. I don't think any level of comfort or salary or changes or housing can really drive everyone to stay put to do this work. You have to have the heart to do it right now. And a lot of Haitians are showing up for other Haitians today.
Really incredible reflections there. And I think what I'm really hearing across all of you is that it's the both and, right? That we need to hold in our hands both the incredible appreciation, admiration, deep respect for the resilience and the commitment to saving lives and the commitment to their profession, while also remembering that all people deserve rest, people deserve wellness. Just because you're a health professional doesn't mean, in Haiti, doesn't mean that you don't deserve rest, wellness. And so what can we do to both honor the commitment, the hard work, while not feeding, as Marc said, feeding this sort of pathological resilience narrative, the expectation that people keep doing that. So let's hold the two in the balance And I heard some very concrete recommendations there too about, what funders can do to support the workforce, housing, better salaries, appreciate the inflation rates, for example. Think about wellness supports added into your grant, etc. So before we turn this over to some questions from the rest of the audience, I'd love to ask all four of you about your moonshot. Just because Haiti is in a place of some chronic emergency doesn't mean that we can't dream and that we shouldn't dream. So I'd offer each of you, what's your moonshot, your best dream of where you would like to see us moving over the next few years as a health sector in Haiti?
I'll step in. For me, I have three keywords for that: leadership, governance, and accountability. I don't think we can envision a better Haitian healthcare system without the leadership and governance, particularly at the public sector. That's where the big change is going to happen, even within the context of this conversation, like strength in partnership. Let's never forget about the local governments at any level, very like a county, town, department, and central level. They are a key part of a successful partnership. As much as we all can come together, if they are not part of this process, it's going to be very challenging. And again, accountability for us, but also for them when they are part of the process.
I want to add on to what Wilfrid just said. I've been thinking about this question for some time and what that means. And I think often when we talk about healthcare, we think of big cities, we think of Port-au-Prince, and we often forget the lack of access to far out remote communities. And honestly, the dream in our healthcare system would be when families and people no longer have to walk hours to find a health center. And that basic health center aspect will save thousands of lives in preventative care if we can really implement access in all of rural Haiti. And then the second thing that I want to add on is that decentralizing specialist care and resources. I think that is still extremely challenging, that all of us throughout Haiti sometimes still have to refer patients to Port-au-Prince for certain exams or to see a certain specialist. And I think the more we move towards that, and we're talking about decentralizing a lot in resources and materials and ports and access to have access to the country, but I think we really need to emphasize on what does it look like to decentralize some of these resources, and also to decentralize and having access to specialists in far and remote communities.
Oh, wow. My moonshot, big dreams. I really think is actually looking at health as part of an ecosystem rather than health in a siloed sense. I think that becomes a big stuff. I know we talk at PIH a lot about staff space systems and social support, and how do we put that together? And really, if we see health, we know health has to go with the economics, right? How do we increase how do we invest in the local economy in a way that the need for certain illnesses has decreased? We're not seeing those as often. Why? Because if we're able to help increase that, malnutrition should decrease, right? We should have if we're able to work within those health ecosystems. And it might take a while to go into that, but there's multiple parts that we're looking at. We talk about the SDGs, and what are those things that we need to address when we're talking about health? That really is my big part. I think that my moonshot, and of course, this is involving with the ministry, working together with them. I wish some of our larger partners will look into the health. Sorry, I'm traveling, so you're hearing the background noise.
Well, you all completely stole my thunder in a much better way than I could. And I'm sorry, Mark, I didn't continue on okay. So I'll add on just ad lib. You know, one thing that I notice continually is, you know, Haiti has so many natural resources and, you know, wonderful ability for and has a long history of producing so much. And you know, the governance, the lack of corruption, and then also the lack of aid organizations killing off business in Haiti, I think would be very, very important to the long-term economic success, rather than shipping in, you know, tons of rice and killing off the rice industry. Let's enable that industry to come back here and allow Haitians to care for Haitians. So I was going to say free and fair elections, because that means that the security situation is partly resolved and we can start to get some stability back. You guys said that so much better than I could. So that's my my input.
All right. Thank you. That leaves, I think it's really important. I'm someone who's worked in emergency, chronic and acute all over the world. And I think we need to continue to remember and encourage one another to dream in those locations, because emergencies are, you know, protracted and ever more protracted around the world right now. And that can't, although it will cause us to change direction or pivot or be more agile in how we're solving problems, we can't dial back ambition or dial back our expectations of ourselves and of our community in those contexts. We're going to turn over to questions from the audience now for a few minutes before I wrap up. I think that we've had a couple of questions actually about the loss of healthcare professionals in Haiti, and how your organizations are feeling that, what's happening with that, and how are you adapting?
Should
Well,
yeah. Oh, go ahead, Dr. Cadet.
no, it's one of the new challenges, but it was already there before. But I would say now it reaches a level of acuity, because we're seeing people leave very fast, almost every month. They have to look for a better future. And of course, that puts the burden on those who remain on site to do the work. And to make the situation even worse, Adeline, you mentioned the donors fatigue. So we are in this tough situation. Should we replace everyone who leaves, or should we try those who stay there to do the work that of two? Because the resources that we have are kind of draining out. It's a fact, we notice it. I mean, the donors fatigue is real. There's also the fatigue of the Haitian population that has to cope with everything. So in order to put it very simple, it's a tough situation for us. Yes, we are trying to be smart, quote unquote, in deciding when to replace and when not to replace, and at the same time to show, I would say, proximity to those who remain on board. Proximity in terms of to show empathy, because we are all living in the same boat, and to really try to learn about what that person is going through on an everyday basis, the family level. And the mental health that Marc mentioned earlier has become part of the, providing some support to the staff. And compensation, unfortunately, that has not been able to be materialized, because, as I said, no resources are coming in right now because of all the narrative that you hear internationally, because the donors do not see a difference. And unfortunately, things are being done. Things are being done every day, whether this is in the Artibonite, in Fond-des-Blancs, or in Mirbalais or Upper Central Plateau. Patients are, to throw out some numbers, in the midst of all this, over the past 3 months, the outpatient visit at the hospital in Fond-des-Blancs has increased by 30%. So, it's getting tough on those who remained.
Yeah, we're definitely a smart organization. I'm sorry, Marc, go ahead. I keep stepping on you. Go ahead, Marc. So we're a smaller organization, so that, you know, has an outsized impact. But, you know, we've lost physicians that have left and gotten jobs in France and Africa, and other staff that have left to the US. So one of my goals with Haiti Air Ambulance on the clinical side is to, you know, right now we have a few expats that still rotate down and work, is to make the clinical side entirely Haitian, with Haitian physicians and Haitian staff. And we're very close to being able to pull that off in the next year, but this has set us back probably by a couple of years, just because we've lost 50% of our physician staff, about a third of our other staff, and a lot of those are really core people who have great skill sets, and because of that, that enables them to leave. So it's down to, you know, very bare bones. My immediate concern is if there's another large earthquake or a hurricane or something that really requires us to surge, that we just don't have the capacity. We're at max capacity on a daily basis, just because we're not able to recruit for the people that have left either. So.
For us at HAS, because we've been around for 67 years, a lot of our hires are actually local hires. What we're finding difficult is, you know, when we're losing a specialist, right? And I think everyone here is having the same difficulty. Certain specialist physicians, those are a little bit more challenging to recruit, but it's an ongoing process. We're constantly, you know, post an opening, we have an opening, we do a recruitment process. And then it's also, you know, just leaning heavily on our team leaders to train this new group of people coming in, right? I think it's very hard for institutions to lose leaders that have been in place for 10, 15 years, right? Like some of the programming challenges involved there too. But on our end, our focus has been, okay, let's recruit and try to find new talent, but also accompany them and train them and do a lot more in the onboarding process, because the expectations and the training is not really what we would typically find in regular times in Haiti.
Sorry, I went on mute. I would add some of the things that we're doing. It's super difficult, and we're hemorrhaging right now. And I don't think people realize we're hemorrhaging some of the brightest brains. And recently I was able to be in Canada for another presentation, and we had some members of their government there, and we're like, Canada's killing us, and we need to look at another plan. You can't, especially for our nursing staff. I believe I spoke to the ministry of the the departmental of the RTBD, the departmental director, and we were talking to him, and he said like 80% of our midwives are gone that we've trained in the country. And we had to talk to Canada, and I'm considering to do an op-ed there, really discussing, like, if we're talking about that, can we streamline it? How can we protect it? Because at the same time, we're investing in training and continuously investing in training, but I'm training for you. And if you're talking about investing here, then that's actually, I'm not saying not to go, but I'm saying, how do we make it so that there's a period that we're able to, and this is not just now, let me be clear, this is not just during this crisis period, but they are actively recruiting from Haiti. Same thing with the US with this whole Biden program. There's aspects of it I agree with, there's aspect of rollout I disagree with it heavily. And we've been lobbying to see how we can go ahead and discuss and get an op-ed. It's been denied. We're going to rewrite that op-ed and say, like, because the process and what it's done is, at this time, you are destroying a country, because the way the rollout has been done, because you're not providing visas for people to do regular visits. And that's what a lot of people wanted, was just regular visitor visa, but we're unable to obtain those. And a lot of my staff had to tell me, because I had no option, I had to go through this option of Biden, because we put all the regular visas for years on hold. And so there's the way the rollout has happened, that we're saying you have to be considerate and you have to think about, and you need to include the people that it's going to be affected in the country if we're the partner. So there's things that are happening that are undermining our ability to continue. We have lost residents, pediatric, in their residency right now. And now I have to figure out is how to increase more attending so that we can provide the care, because we're going to have a gap in the country of pediatric residents that are graduating. That means in 2 years, we don't have any because that whole class is essentially gone. So they have to consider these things. What we are doing, I can't tell you this is the plan for today because it's a constant evaluation and it's a constant constant planning. So what are we going to do next? How are we going to do this? What do we compress? Make the decision. What do we increase? What trainings do we put? What services can we offset to others? That is possible. And at the same time, we're developing a somewhat school, like you were talking about, Jessica, that to train people, right? Like to bring them up to that standard. Because for instance, we have an oncology program. Hard to find pathologists before, and it's even harder now because pathologists are leaving. So we're down to like one pathologist. So these are the issues. So now we're developing a pathology tech, not to do pathology, but to offload some of her work so that the pathologist can do the work. So in these senses, we're constantly adapting. And every day, I will tell you, if not every week, I'm like this. Okay, let's get the team together. What are we going to do? That is a weekly situation that we're dealing with.
All right, I think we're going to have to wrap up in a minute, but I want to note some really interesting comments in the chat here, still on the note of this catastrophe of brain drain, which is maybe not the word we want to use, but do all of you, there's the issue of international policy, immigration policy, et cetera, how that's been rolled out, which I'm so happy to hear that there's some attempts to do some op-eds around that. Beyond that, which is the true kind of root of the problem and the structural issue, what are ways in the short term that institutions can better incentivize their staff, their human resources to stay, and what role do donors have in that? What can we do to help you to hold on to your staff in terms of working conditions, salaries, et cetera?
I would just share some of the things that we're already doing, like we talked about a little earlier, is that staff wellness. That seems to be a big support for our team that has helped people stay. We've had to provide some social support for staff that were in more dangerous areas, assist them in being able to move out of those dangerous areas so that they're not worried about their families and so forth. We had to increase housing into our different sites so that staff, we could decrease their time on the road and don't have to necessarily go back to those areas. We have to, like, literally, we're talking to some schools to see how, in one way, is how can we improve the schools in the local area, because they're just not up, because the staff is coming up with their kids. Their main concern is the quality of the schools. So how do we help influence that so it makes it a real viable option for them? So those are some ways. I'm not saying that for staff pay or salaries, it goes more with the restructuring because of the staff loss. So we haven't necessarily increased salaries, but those that had more work and we decided not to hire in those, is how do we manage that so that we're being fair to them, but fall within our salary structure and so forth. So we're looking at our salary structure so that it doesn't become a one-time person, but it looks at a grille salarial so that they can move to that next level, because you're now taking on more responsibilities and so forth. So there's some ways that we're working at it.
On our end, I think what's challenging, and this is where I kind of like have to say there's only so much that we ourselves have team leaders can do in this context. I think a salary increase, building wellness program, implementing restructuring. But I think my biggest fear is I'm afraid we're gonna run out of options, right, to address this need and this gap. And I think there needs to be real serious conversations about the impact of us losing a whole generations of professionals that were trained in country, that understood the local context, the local needs, and what that means long term. And my biggest fear is that it will take us too long to say there's a fire in this house right now, and we won't have time to put the fire out. I think it's great that we can take steps independently, has great and larger institutions, but we need to look at the bigger picture, is that we may be able to offer a more competitive salary that maybe 120 other healthcare institutions can't. And us here on this panel will not answer the healthcare needs of an entire country. And I think we really need to create a channel for advocacy, for better security situations, and overall change in policy, because I don't think we will problem solve this on our own. I think, I'm a bit of a problem solver, and I'm always thinking ahead and I'm planning ahead. I'm afraid we're going to get to a point, if things don't change on the ground in Haiti, where that's no longer going to be an option for us, right? We're just going to lose a lot of professionals. It's going to take years and years to rebuild what we've already lost, years and years to build it back up again. And there's the nuance of Haiti being where it's at, French speaking, Creole speaking, it's unique circumstances that makes Haiti Haiti, where you're not quickly going to be able to pull from other countries when the security situation gets better to build that capacity back up. It's going to have to be Haitians building that capacity back up. And I am afraid and a bit saddened to see that we're losing all these professionals that have taken years and years to train. And Marc knows this too, because, she's talking about training a residency or a group or a cohort. There are already limited spots for these opportunities in Haiti. So to have to lose the few elite group that we get in this position in their career to completely leave the country is just extremely complex. And I'm afraid that we can continue to take these steps, but there's a void and there's a gap outside of what we can do with our resources, and we have limits as well. And I think the discussions about security needs to be held, the discussions about advocating, leveraging our voices together for better policies also need to be held.
I'll keep my answer short because we're running out of time. Adeline, I acknowledge that. In another conversation, someone on this panel mentioned knowledge retention as a remedy to the brain drain, and I think this is totally correct. So we need to start thinking for the next 10 years, how to replace those who will have left the country. And yes, we're talking about healthcare professionals. Personally, for having been a hospital administrator, I'm quite sensitive to the situation with other workers like plumbers. So how do you run a hospital without good plumber, electrician? And so this is real. And then the specialists that Jessica mentioned earlier, pediatricians. And just this month in June, we lost 2 emergency room physicians. And our emergency room in Fondation, every day at any time, we have more than 30 patients in there. So this is real. So knowledge retention, and again, long-term planning, advocacy, you mentioned that, but also looking across other specialties like plumbing, electricity, accounting, and any really valuable resource that we have in the country.
And just 30 seconds, I think building on exactly what Dr. Cadet said is, from a donor's perspective, yeah, we do have some ability to increase, staff pay and that kind of thing. But when, your key staff comes to you, who you've already moved to a different part of town, or you've already provided other housing, and says, I can't raise my children here and I have the opportunity to leave, I can't argue with that. So money won't necessarily fix that problem. But if you bring up plumbers or electricians, they're becoming scarce, which means they're able to demand a much higher price. And to get any work done reliably with good help is costing us tremendously more, which then drives our operating cost up. So.
Well said. I'm going to try to do a really quick sort of actionable summary and then let us go back to your very hard work. I think that, and I'm looking at the chat as well, we keep coming back to this sort of, you know, wringing our hands. This is such a complex situation. It's, you know, ongoing complexity, and how do we find a way in all of this? Yes, that is absolutely true. But I also encourage the audience of this group to almost like take a deep breath for a second, because we actually do have a lot more power than maybe we pretend we do. We have power to collectively, now I'm talking about communities of donors, right? We see a community of health institutions here, but we're also a community of donors. If we're collectively advocating for structural and systemic change in the way aid works and the way that, you know, both state aid and philanthropic aid works, we can make some changes. Very specifically, let's all have a call to action to have more trust-based funding. De-restrict your grants as much as you possibly can. Make them multi-years. Our foundation has made all of our Haiti grants, now they've gone from 3-year standard to 4-year standard, and usually they are repeated multiple times. Look for networks of organizations. Don't go nonprofit shopping. Look for networks of organizations, coalitions that you can nourish by giving them all grants or supporting them in an unrestricted way to work together. Reduce your paperwork. Please, let's help if we're incredibly short-staffed. Let's minimize the paperwork as much as possible so people can do their jobs. Be involved, be paying attention and sending encouragement without overstepping donor boundaries. And finally, perhaps most importantly, fund mental health and think about everything we can do to support health workers, which includes wellness, housing, supplies, make sure that they can do their jobs as best as possible. Salaries, education for their children, and safety for their children. Let's collectively pledge to try to improve working conditions immediately for health workers so that we can better retain folks as best as possible. So in closing, I'd just like to really deeply thank Wilfrid Cadet, Jessica Laguerre, Marc Julmisse, David Ellis for your leadership, for everything that you're doing together. I want to thank Health Equity International for hosting this today. And they are celebrating their 40th anniversary right now. So bravo, we wish you another 40 years or another 100 years. There are links to all of these organizations on your screen. So please consider donating or providing your support and encouragement. And I guess I really hope that everybody here today can continue to follow the work of these 4 organizations and the many other organizations that they're working. So. Thank you, everyone, and bonne continuation.
Thank you, Adeline, for hosting us.
Thank you.
Thank you so much. This was a great conversation.
Thank you.